Well, for colorectal cancer, which is a disease I've looked after for several years now, there's really been a transformation in outcomes for patients from about 8 months median survival for metastatic disease when I started looking after the disease to over 2 years in the majority of series that are published. And the reasons for that have been the availability of new cytotoxic agents over the last 5 years, oxaliplatin, irinotecan, and the oral fluoropyrimidines, but also rather more aggressive use of these agents and clearly the big impact that the biological agents have made. And until recently, we've had 2 major biological agents, the EGFR inhibitors, and we've also had the angiogenesis inhibitor, Avastin. The big problems, of course, have been how best to use those, and we've tended to use them in ways which perhaps are not best evidence-based. We've also, in the last 6 months, had 2 new agents. We've had aflibercept, which has become available as a novel angiogenesis inhibitor, and we've had regorafenib for the third-line setting, and that's an oral TK inhibitor. Aflibercept, which is different from Avastin in several ways. It's an agent which is also called VEGF trap and is an agent which is targeted at the VEGFR1 and 2 receptors. It also inhibits platelet-derived growth factor receptor and therefore has several potential advantages over Avastin. The advantages it has are that it may have a greater angiogenesis inhibitory effect, but it also may have a lower toxicity profile. A big trial called the Valor trial looked at aflibercept in the second-line setting and gave it with a FOLFIRI or FOLFIRI given alone. And the results were really moderately impressive. They showed that there was a median survival benefit of about 6 weeks, but I think even more interestingly was the fact that at 2 years, over 10% more patients were alive, and actually that 10% benefit seems to be going out towards 3 years. In addition, it increased the response rate by 10%, and that response rate benefit hasn't actually been seen with Avastin. So possibly this agent could be used to downstage disease for operability in the future. New trials might be looking at that, but it also appears to give a survival advantage in the second-line setting, which hasn't really been seen with Avastin. Regorafenib was looked at in a large third-line trial, which gave this agent with best supportive care or best supportive care alone as a comparator. It's an oral TK inhibitor. It's given for 3 weeks with a subsequent 1-week break, so slightly more complicated to remember the regime, and it hits many targets, all the VEGF receptors and also many other receptors. In the third-line trial, it improved median survival, again by about 6 weeks, which seems to be the survival benefit we see with most of these biological agents. As with all of them, it did have some side effects. Lethargy, skin rash, diarrhea increased in the active arm. So we're really in a situation where we now have 4 sets of biological agents for metastatic colorectal cancer. We have Avastin, we have cetuximab as the EGFR inhibitor. We've now got aflibercept in the second-line setting, and we may have regorafenib in the third-line setting. What can we actually give that is funded? Well, in England, the Cancer Drug Fund has approved bevacizumab, Avastin, in first or second-line settings with FOLFOX or FOLFIRI, and very recently this week also accepted single fluoropyrimidine as the chemotherapy addition in the first-line setting. You can use bevacizumab in the second-line setting if it hasn't been used in the first-line setting, but only with oxaliplatin-containing regimes. And in the second-line setting, we can now, in the Cancer Drug Fund, give aflibercept. So the new treatment paradigms will need to be drawn up with that in mind, at least in England, where we can use all of these agents. Clearly, cetuximab can be given, as with NICE approval, to downstage liver metastases for surgical resection. We can use Avastin or cetuximab in the first-line setting with FOLFOX combination chemotherapy or single agent therapy. And in the second line setting, we can use aflibercept with FOLFIRI, or if it hasn't been used in the first line setting, Avastin with FOLFOX regimes in the second line setting. We'll know once registration has been approved whether or not we'll be able to obtain regorafenib under the Cancer Drug Fund. So many options, many different choices in first, second and third line setting, and of course in third line we can use cetuximab in England. The question is really still to be answered, what's best when? And that still remains a question we need more answers for. And I'm hoping in ASCO to hear some answers. There are going to be 4 quite interesting presentations. One is going to examine whether or not the use of capecitabine with Avastin bevacizumab in a maintenance setting after first-line chemotherapy does add to survival. The abstract suggests that is going to be the case. We're going to be seeing the big Swiss study results, whether or not maintenance Avastin on its own after first-line chemotherapy adds to progression-free survival and survival. And then there's a study looking at FOLFOXIRI versus FOLFIRI with Avastin. That, again, will be an interesting study to ask whether that improves downstaging and survival in the more aggressive arm. And then finally, there's quite an interesting study looking at FOLFIRI with cetuximab or FOLFIRI with Avastin in the first-line setting. I think all of those are going to help us to answer what the best forms of treatment are for our patients in different lines, and they're going to add to our ability to refine our treatment algorithms.